Hello, everyone, and thank you so much for joining us to the special programs where we're gonna dig into a deeper dive into this ever-evolving first-line space and the HER2 positive metastatic breast cancer. I'm joined by two titans of our field on oncology, Dr. Rao and Dr. Pegram. I'm Jason Mouabbi. I'm a breast medical oncologist at UT Anderson in Houston, Texas. Dr. Rao?
Hi, it's my pleasure to be with you both tonight. My name is Ruta Rao. I'm a breast medical oncologist at Rush MD Anderson in Chicago.
Thank you, Dr. Rao. And Dr. Pegram?
Good day. I'm Mark Pegram. I'm a medical oncologist at the Stanford University School of Medicine in Palo Alto, California. Thank you for
All
inviting
right.
me. Great.
Fantastic. Thank you so much, Dr. Pegram. All right, we have a very exciting discussion today. But first, before we dig into the new, brighter, and shinier new agent, first we need to give credit to the decade-old standard of care, the Cleopatra regimen. Dr. Pegram, I'm going to start with you. Can you give us a little bit of an overview, a little bit? I love the history lessons you usually give me when I sit next to you. So can you tell us a little bit about how did the Cleopatra regimen come about? And was it by design that we were going to do an induction phase followed by a maintenance phase, or we had to do it? We had no other choices.
The Cleopatra regimen was designed to test the efficacy of pertuzumab in first-line HER2 positive metastatic breast cancer. And in this case, it was combined with trastuzumab and a taxane in the THP experimental arm of the Cleopatra trial. Cleopatra is, in fact, an acronym. It stands for Clinical Evaluation of Pertuzumab and Trastuzumab, so it actually has a meaning. Um, the results were outstanding. Pertuzumab added significantly both to PFS and, importantly, to overall survival, even with long follow-up. The shift in median overall survival was something like 16 months, so it was really impactful, withstood the test of time. It was approved, I believe, back in 2012, so it has been the standard of care for first-line HER2-positive metastatic disease since around 2012, so more than a decade. It's been tried and true. Dang it all up at Memorial did a phase 2 trial substituting docetaxel with weekly paclitaxel in the same dual antibody regimen, got point estimate hazard ratios that were similar to the experimental arm of Cleopatra. So practicing clinicians for all these years have either chosen weekly paclitaxel as the taxane base or docetaxel as the taxane base. Either one can be used with the dual antibody regimen in practice historically.
Yeah. No, fantastically. So, Dr. Rao, this induction followed by maintenance, I think with the Cleopatra, we had to do it because patients were getting toxicities from the taxane that it has to be stopped. You couldn't do it until progression. It has to be stopped at some time, especially we're talking about neuropathy. So that led to this induction followed by maintenance. Can you talk to us a little bit more about that and how useful it is for you in your practice to have this approach?
Sure. So, like you said, I think it, came about in practice. That's not how the trial was originally designed, but we know with the taxane, with either docetaxel or paclitaxel, neuropathy is a cumulative toxicity. So patients can only receive so many cycles of this. And in the metastatic setting, our goal is to give these patients a good quality of life while giving them good disease control. So we really have to monitor some of these side effects like neuropathy. And I think that's where we really came up with this 6 to 8 cycles or treat to best response. And then what we do is we generally stop the taxane, hold the taxane, and continue the HER2 directed therapy. I think the other thing we do in clinical practice that's a little bit different than how Cleopatra was designed is for those patients who are ER positive, HER2 positive, we also add the endocrine therapy. And we've seen some really good long-term results with HP plus minus endocrine therapy if the patients are ER positive as well.
Yeah, no, for sure. No, thank you so much for that insight. All right, so like you said, it's been a little bit over a decade. We've been using THP. We've been doing it with induction followed by maintenance. People have gotten accustomed to it. They like it. The study initially showed a median progression-free survival close to 18 months. But there was still an area of unmet need. Dr. Pegram, can you lay this foundation for us? What was this unmet need that we still needed to go for something better?
Well, I mean, with a median PFS of 18 some months, patients can and do eventually progress on the Cleopatra regimen, unfortunately. There are, of course, rare exceptional responders who have clinical complete responses with the Cleopatra regimen, but they're few and far between, unfortunately.
Mhm.
Those are among the patients that seem to have these very long, durable responses, even with HER2 positive metastatic disease, some of whom apparently never progress historically.
Mhm.
But that's the minority fraction with that regimen. Most patients eventually progress and have to move on to second line therapy.
Yeah, for sure. For sure. Dr. Rao, so here comes DB09. DB09, it's trying to move a very useful, I think it's the most important drug in the journey of a patient with HER2 positive metastatic breast cancer, trastuzumab deruxtecan, moving it to the front line. The DB09 was that study. Can you give us an overview of that study?
Sure. So this was a randomized phase 3 trial looking, again, like you said, in the first line setting, and it's a 3-arm randomization. So patients were randomized to the Cleopatra regimen, the THP, or trastuzumab deruxtecan with pertuzumab, or trastuzumab deruxtecan with placebo. And so we don't yet have the results of the trastuzumab deruxtecan placebo arm because that median follow-up has not yet been reached. So really what we're talking about when the results and the publication that we've seen is comparing THP to the T-DXd plus P arm.
Mhm.
These patients had not previously been treated. They could have been allowed to have one line of endocrine therapy. So it's important to keep that in mind that this is really a first line trial. So it's really moving it up in the patient's treatment journey.
No, for sure, for sure. I mean, the results speaks for themselves. I mean, before they showed us the result, we were doing some bets between us. What do we expect the median PFS to be? And we were all, I would say, like astonished to see a median PFS that was above 40 months.
Mhm.
Dr. Pegram, what do you have to say to that?
Oh, the study met its primary endpoint with flying colors. Hazard ratio of 0.56. P-value exceeded the O'Brien-Fleming target p-value with 4 zeros after the decimal point. And so just very robust statistics. The Kaplan-Meier curves separate early within the first few months of follow-up, and they stay apart, pretty much till the end of time. At the median, there's a 13.8-month delta in median PFS. So once again, with this molecule, the single most active HER2 targeting agent, T-DXd, we see very robust efficacy signal here in the first line. And so this is unprecedented in as much as it replaces the old standard of care, which has been around for so long.
Yeah, I think one of the things that was really exciting for me is looking at the complete clinical responses. The complete clinical responses were in the upward of 15%. Dr. Rao, what is the significance of that, in your opinion?
I think it's remarkable to see complete responses in these patients who have metastatic disease. But I think, even though we see a few of them with the Cleopatra regimen, this was almost double what we saw compared to THP. So it's really nice to see that patients are having such a great response. Other endpoints were also prolonged, the duration of response, the overall response rate, including complete and partial responses. So it was really nice to see that a number of the secondary endpoints were met as well.
Yeah,
And
I mean,
the
yeah,
overall,
go ahead, Dr.
the
Yeah,
overall response rate was 85.1%.
85.
I
Yep,
mean, we've just never seen anything like
we've
this.
never seen that. Yep,
Extraordinary. I
it
mean, the
is, it
control
is.
arm performed well too in this trial, I have to admit. It was like 78.5% objective response rate for the THP arm, but still 85% is unprecedented, and it's the most active regimen I've ever seen in HER2 positive metastatic disease.
Yeah, no, for sure. It was really exciting. For me, I zoned in on the complete clinical responses. That's because there we say we can cure maybe a minority of those patients, even in the metastatic setting. I mean, that's what's really exciting to see in that population. Because historically, we always thought about metastatic disease. We're lucky if we get the response, stable disease, we take it as a win. But now we are moving the needle in getting deep responses where you cannot see evidence of disease in 15% of the population, which is really exciting in the first line setting. But now let's shift gear a little bit. So what do we say to the doctor that tells you, all right, I like T-DXd as my salvage option. I'm gonna start with THP and keep T-DXd in my back pocket. I mean, this back pocket, I want to know what's available in the back pocket. I hear it all the time. What do we say to the physician that still have that understanding that I'm gonna wait when the disease progresses, then use T-DXd, but I'm gonna stick to THP? I want to hear from both of you. I'm gonna start with Dr. Rao.
So I think one of the most remarkable things to me was that learning that 25 to 30% of patients actually don't go on to second line of therapy. So, sometimes you may not get the chance to use what was in your back pocket for these patients. So I think that really emphasized to me that it's important to give our strongest agents first.
Yeah. Dr. Pegram?
Same. I mean, if you read DeVita's textbook of oncology, which I did, back in the day as a fellow, I was taught that the general, theoretical optimal strategy for sequencing active agents in metastatic solid tumors of all tumor types, not just breast cancer, is you start with your most active regimen first and get as much mileage as possible out of that regimen. And in the long run, that will give you the optimal results compared to trying to save more effective treatment for later, because there may not be a later for a sad fraction of patients, for one thing. But the optimal treatment in terms of tumor burden reduction, relief of symptoms, palliative outcomes, maintaining quality of life, is to get an early and quick and durable, hopefully, response and maintain it as long as possible. And these are largely, except for the exceptional responders, these are palliative treatments. So it's really important to get control of the tumor early and then, maintain it and then use salvage agents in later lines that may not be as active as your first line treatment.
Yeah, no, for sure. Like two things here I will add. First is that the NCCN understood the value of that regimen, and on the most recent iteration, it is part of the guidelines now in the first line therapy to consider the regimen of the DESTINY-Breast09. The other thing I always tell people, I'm a big basketball fan, and Dr. Rao is from Chicago, so I'm going to mention like my favorite player and the GOAT, in my opinion, is Michael Jordan. And I tell them, if you have Michael Jordan on your team, you don't put him on the bench and play the game with French player and put him in the fourth quarter expecting to win the game. If you want to win the game, you have to put your best player from the beginning, right? So the best chance for our patient to out-survive that cancer is to get their best agents as soon as they can receive them, because that's when you're in charge of the situation. That's when you can give that medication and expect the great results. Because you're right, Dr. Pegram, down the line, you're not in charge of this situation. You don't know when the patient progress, how they're going to be. Are they going to have a good performance status? Do they even want treatment at that time when they're progressing, or are they able to handle treatment? So these are very, very good points. One thing
I like your Michael Jordan analogy. When I was a senior in college, Michael Jordan was a freshman, and he shot the winning shot for my team, the UNC Tar Heels, back in 1980. They won the championship.
I like that analogy too. I'm going to use that as well.
Fantastic. All right. One of the things it really struck me from the DB09 results is how well the patient with PIK3CA mutation did on that study. Because we know about 30%, about a third of the patients with the HER2 positive disease do also have a PI3 kinase a mutation. Dr. Rao, what can you tell us about that? And how does THP does with patients with PIK3CA mutations?
So generally, we know that patients with PIK3CA mutations tend to have a worse prognosis than those patients with wild type. So I think it was important to see in the subgroup analysis that even in the patients with these PIK3CA mutations, that T-DXd outperformed THP.
Yeah. So there was a paper published in JCO after the Cleopatra paper where they looked at subgroup analysis. Dr. Pegram, do you know what the paper I'm talking about? And can you tell us what it showed in patients with PIK3CA mutation?
Yeah, they do have a worse prognosis when treated with standard chemotherapy or even some HER2 targeted agents. For example, I was the senior author on a paper that we published looking at the TDM1 Amelia pivotal trial with a control arm of capecitabine and lapatinib in those days. And in the control arm, the PIK3CA patients did far worse compared to the PIK3CA wild type patients. Whereas in the TDM1 arm, they responded, even in the presence of PIK3CA mutations, to the same degree as the wild type patients. So this seems to be a general feature of HER2-directed antibody drug conjugates, both TDM1 and now the T-DXd, also showing the same phenotype of, identical hazard ratios, irrespective of PIK3CA mutational status.
Yeah, and I think for me that's one of the biggest push for me for the argument of people that say I want to use THP first. I tell them like there are a significant group of patients, a third of your patient really are going to respond very poorly to that regimen, and you don't have to worry about it when you give them T-DXd plus pertuzumab. So that's one of the other more like building up on the arguments why it's so much better to proceed with that. Now, a lot of people love the maintenance regimen. So I wanna spend some time talking about this maintenance strategy. About 10% of the patients on the DB09 for one reason or another, mainly tolerability, at some point had to switch from the antibody drug conjugate to the naked antibody. So go from T-DXd to H. So they continued HP. So kind of receive maintenance. We don't know how those patients did so far, but hopefully in the future we'll have a subgroup analysis on those patients to see what happened. But people love their maintenance strategies. Doctors love it because patient can get a breather, because we've been used to it with THP. Do you foresee, and this question is for both of you, we can start with Dr. Rao and then Dr. Pegram, do you foresee that a maintenance will be eventually implemented on patient receiving or starting with T-DXd pertuzumab, or you are from the camp, no, we should treat until progression with that same regimen or tolerability, of course? Dr. Rao?
So this is a challenging question. I think it's, we're so used to doing the THP where you give 6 to 8 cycles of taxane and then going into maintenance. So that's really kind of our habit. But we have to remember that DB09 was really done with T-DXd plus P until progression. And if you look at the progression-free survival curves, as you've mentioned, they separate early, but then they continue to separate the whole time. And so I think we don't really know that switching to a maintenance regimen, and even if you think about adding other targeted therapies in that maintenance regimen, will give you the same median PFS that we saw in DB09. This was really for those patients who were treated T-DXd plus P until progression. Now, I think a lot of this is going to be individualized when you see the patients, how they're tolerating treatment, how they're responding. So I think, of course, in practice, we may make some adjustments, but I think when we think about it, our goal should really be to think about treating until progression.
And I think you raised a very important question, that the separation truly happens after 6 months. So this notion that I'm going to do similar to THP, induce my patient for 6 months with T-DXd and then move on to give them maintenance. And that's, by the way, what the Demeter study is trying to do. Mm-hmm. That's why I don't like this notion of doing a certain number of cycles, then to go to maintenance. I feel a much better way is to a pragmatic way to treat to best treatment response, and then do the maintenance strategy, then to do a finite. Because you're right, the separation keep on happening. And I think if my memory holds me correct, up to 2 years, you still see separation. Then you can see some leveling of that. Dr. Pegram, what do you think about that?
Yeah, I mean, we want to get as much mileage out of the most active agents as possible in this metastatic setting. That said, there are some patients who simply can't take T-DXd forever. It does have cumulative toxicities. In my experience, primarily cumulative fatigue in the end. Even on DB09, the median duration of treatment time in the experimental arm was 21.7 months. That's the median. Even though the time to median PFS was 40.7 months. So the average patient didn't make it all the way to 40 months. There's no question about that. So ergo, some patients do go on to a maintenance short of progression, even on the T-DXd treatment. That said, to get the maximum mileage out of the most active agent that we have for HER2-positive breast cancer, you can do dose modifications. Those are in the prescribing information. This is an FDA-approved regimen, by the way.
Mhm.
And so you can simply reduce the dose of T-DXd according to tolerability, including fatigue. Patients will do much better with the fatigue adverse event
Mhm.
with dose modification. It really does work. Moreover, I've had patients where I've extended the dosage interval when they're
Mhm.
still responding. They're many months or even more than a year on treatment, and they just, need a little bit of a break. I can switch it to every 4 weeks as long
Mhm.
as they're otherwise tolerating it well and have no evidence of progression. And that's worked, and people can get even more mileage out of this active regimen than simply switching early to a dual antibody maintenance with or without endocrine therapy, depending on their hormone receptor status.
Yeah, and I like what you said about the 4 weeks, because the half-life of TDXD is 5.5 days. So it takes 5 half-lives for the drug to become undetectable.
Right.
So you're way into your 4 weeks. So if
Sure.
you extend by 4 weeks, it makes perfect sense. Dr. Rao, I want to go back to you because this maintenance really took a lot of ground, especially because there was 2 studies recently presented showing us maintenance strategies. There was the PATINA study in the triple positives, and there was the HER2CLIMB-05 that was in open population, adding to catenin to HP. So first, I want to start with you with the PATINA. Can you tell us a little bit about the PATINA and what did it show?
Sure. So PATINA was a trial that looked at patients who had received 6 to 8 cycles of their induction chemotherapy with trastuzumab and or pertuzumab. And then at that point, they were randomized. So keep in mind, these were all patients who were ER positive and HER2 positive. So at that point, they were randomized to endocrine therapy alone or endocrine therapy with palbociclib. So this was exciting for us because this is really the first time we had seen a trial showing the benefit of a CDK4/6 inhibitor now in ER positive, HER2 positive breast cancer. And just to summarize, the trial did show a median progression-free survival of 44 months for those patients who received palbo with endocrine therapy and continued their HP, compared to 29 months for the patients who had endocrine therapy plus HP.
Yeah. Dr. Pegram, there is something for me that a little bit bothers me about the patina, and I wanna get your opinion on that. So I always look at the control arm to tell me whether or not there was something bias happening. Like the control arm on the patina, which was basically the control arm of the Cleopatra, did amazingly well. Amazingly well. Like if you look at the Cleopatra, we saw a median PFS of 18 months. Here you're seeing 29 months on the patina study. So there was patient selection. Like I cannot think of any other way to see so much better a patient doing on the control arm compared to the intervention arm. What do you think happened there?
Well, there's a couple of different forces at play here, actually more than a couple. Number one, these are all hormone receptor positive patients, which probably by and large have a more favorable outcome than hormone receptor negative HER2 positive patients in the first place. Number one. Number two, these are patients who had already finished their induction with no progression. If you look at the Cleopatra Kaplan-Meier plots in the experimental arm, there are some early progressors, even while they're still on the THP, and it's upwards of almost 10%. I've done the using a protractor. I've done the math on the graph in the paper, and it looks to be around 9% have progression while they're on THP. It's not common, but it
Mhm.
happens. So all those patients are excluded from the patina population outright. The third factor is the times have changed. And in the DB09 trial, it has a higher fraction of de novo metastatic disease,
Mhm.
which
Mhm.
arguably has a better prognosis than relapsed metastatic disease as well. I think just over a third of patients in DB09 had a de novo metastatic disease, which is probably a more favorable patient population than people who have relapses after neo or adjuvant therapies.
I think to your point, I wanna just highlight it one more time, is that the induction portion was not part of the patina study. The
Correct.
induction phase of THP was done off study, and then patients were able to randomize after based on basically the treating physician and the patient agreeing to go on that study. And whenever you don't do that, there are biases that can come into play over here because you're cherry picking the patient who had the best responses to that induction phase, whereas the other patient who have like maybe small progression or progression, you moved right away to something else. Whereas the DB09 casted a wider net. All patients from the beginning, there was no cherry picking over here, were allowed to enroll on that study. Dr. Rao, so now that we have the PATINA 44 months, so some doctor will tell you, okay, here I see 44 months, the DB09 showed me 40 months. Am I triple positive? I'm still going to do THP and then give them the PATINA regimen. What do you tell this train of thought?
Yeah, I think, we're going to hear this a lot coming up because now we have options in the first line setting. But I really think what Dr. Pegram said was very important. It's important to remember that these were patients who did not have progression on their initial induction regimen and then were randomized, and they were all hormone receptor positive. So I don't know that it's as widely applicable to all patients as we think it might be.
Yeah. And another maintenance strategy was presented recently at San Antonio, the HER2CLIMB-05. Dr. Pegram, can you tell us a little bit about the study design and what did the study show?
HER2CLIMB was another induction maintenance overall strategy. These are patients who had 4 to 8 cycles of THP induction, centrally confirmed HER2 positive disease, good performance status, good laboratory parameters, etc. They were randomized 1-to-1 to tucatinib with HP and endocrine therapy, or placebo and HP every 21 days along with endocrine therapy. And the results showed superiority of the addition of tucatinib with a hazard ratio of 0.64 and a highly significant p-value, a delta at the median of about 8 months and change, I believe. And so this is another theoretical option for patients in terms of a maintenance strategy, particularly perhaps those patients with brain metastasis would be an option if they for some reason can't take the DB09 regimen and have already started on THP, then this would be a logical next step perhaps. But HER2CLIMB-05 has some toxicity challenges. In particular, there's a lot more diarrhea when you add tucatinib, especially with a pertuzumab-based dual antibody backbone. It's over 70% all-grade diarrhea. And there was significant transaminase elevation, and probably I would estimate 35–40% of the transaminase elevations were grade 3 or higher. So it's challenged with toxicities. And so it may not be the best choice for all patients, but it could be a consideration for someone who maybe is not able to tolerate a T-DXd based induction strategy and instead had to get THP, or a clinician was saving THP for later. It is an option, and I think it's an option that could be discussed with patients on a case-by-case basis, just so that they can have an informed decision one way or the other.
I think you nailed it. Here you're doing tucatinib with naked antibodies, right? And it's still pretty toxic.
It is.
Surprisingly, the alopecia elevation was surprising. And it was the reason for discontinuation, which was seen in up to 1 in 4 patients due to alopecia elevation. So that's why for me, especially when I talk about the HER2CLIMB-05, I'll be like, maybe that's not better tolerated than doing the DB09. So that idea is flawed for me when we talk about those. So that's the perfect segue for my.
The other thing I should mention is, HER2CLIMB-05 is really only for the hormone receptor negative patients. In my opinion. The PATINA regimen would be, my default go-to regimen in a hormone receptor positive patient following THP. So really, HER2CLIMB-05 would really be restricted to the HER2 negative patients, and especially particularly for patients with known brain metastasis.
Yeah, for sure. All right, so that's a perfect segue for us to talk about the elephant in the room when it comes to T-DXd, and it is the side effects, right? Dr. Rao, can you take us a little bit what to expect in terms of side effect when it comes to the use of T-DXd plus pertuzumab?
Sure. So I think there's a number of side effects. I think overall we've had a lot of experience with this drug in later line HER2 positive, HER2 low, HER2 ultra low settings. So I think most of us are more comfortable managing this. In the initial trials, we saw a lot of nausea, but I think today We use very aggressive anti-emetic regimens up front. And with that, we're really able to mitigate the nausea. I found in my practice, and I've heard many others say this too, that in addition to using our standard antiemetic regimens, adding olanzapine, and sometimes even for those patients who have delayed nausea, a few days of very low dose olanzapine later on into the cycle is really, really effective.
Yeah, for sure. I mean, olanzapine is, for me, it's a game changer. I do it for all my
Mhm.
patients, low dose daily. I don't do it for a short period of time. I tell them take it daily. I think it's a win-win for everybody. So the patient are winning because their nausea is under control. It also helps them sleep when they take it at night. It is an antipsychotic medication. It does stabilize the mood, so they tend to get happy. And the doctor is happy as well because they're getting less complaints from patients when they go on regimen. So everybody is happy when you do the low dose as olanzapine. So I highly recommend it for everyone that does prescribe T-DXd to try the low dose olanzapine. It is a game changer. Dr. Pegram, back to those side effects. One thing that scares people is the ILD. Can you tell us a little bit about the ILD seen on the DB09 and how should we monitor for it?
Yeah, I mean, there were really no new safety signals in DB09 with regard to the expected and known T-DXd toxicities. One of which, of course, that's unique to T-DXd, and that is interstitial lung disease or pneumonitis, drug-induced. The fraction on DB09 was around 12%, similar to other T-DXd clinical trials in the metastatic disease setting, both HER2 positive and hormone receptor positive, HER2 negative. Most of the toxicity is low grade, grade 1 or 2, can be managed with holding the drug, considering steroid treatment. And in some cases, if it's grade 1, you can even reintroduce the drug. And if it's less than 28 days, you don't even need a dose modification, according to the package insert. But for grade 2, then steroids treatments are recommended for everyone at 1 milligram per kilogram prednisolone equivalent for at least 2 weeks and then a month-long taper. But the main issue that we have for this drug in all cases, in all studies, is to try to mitigate against grade 5 toxicities, because rarely we see grade 5 drug-induced ILD associated with T-DXd. In this trial, DB09, it happened in 2 patients, which is a 0.5% of all the patients enrolled in the trial. And you really do need to spend time taking pulmonary review systems at every clinical encounter. This includes the infusion room nurses should do a pulmonary review systems on everyone. Follow the creatinine closely because azotemia is a known risk factor for ILD, for example, as are a number of other factors, age, hypoxia, so resting pulse oximetry of less than 95% is a known risk factor for drug-induced ILD in this case. So be on guard for it and also screen for it. On DESTINY-Breast05, as is true for all the DESTINY clinical trials, '09 I should say, but the same was true for '05. On study, patients had high resolution thoracic CTs to screen for ILD deliberately, prospectively, every 6 weeks. Now, it may not be feasible off study to do it every 6 weeks on every patient with metastatic disease, in my opinion, but you should probably do it periodically. Most authorities recommend 9 to 12 week intervals for high resolution thoracic CT scans. And this is important because if you're using just like PET CT, the thoracic imaging is not as sensitive to pick up ground glass opacities, which is the most common clinical presentation of ILD are ground glass opacities and high resolution, low dose, actually, these high res thoracic CTs, and they're non-contrast. Those are much more sensitive to picking up ground glass opacities. So you should use them deliberately in concert with your staging CTs. And then look at the staging CTs carefully to make sure that you're not missing some ground glass opacities that maybe were dismissed because they're not metastasis and not progression, and nobody thought much of them. But now you have to take them very seriously and act accordingly.
Dr. Pegram, I have a follow-up question. So you mentioned it because when you said like grade 1s, if they recover, you can re-challenge them. There was a provocative paper by Dr. Hope Rugo that showed that some of the grade 2s, if they recover, they will re-challenge and it did pretty fine. Would you be willing to re-challenge patients that have grade 2 ILD?
Off study, I'm hesitant to do so, just because the prescribing information, the FDA label, does not allow that. But I know of that data, and it looks, it's small numbers, but anecdotally, in Dr. Rugo's and her colleagues' hands, it looks like a number of patients were able to get meaningful extended durations of further T-DXd after grade 2 ILD, and there were no grade 5 events in
Mhm.
that small study. But that study was not big enough to detect a 0.5% of incidence of grade 5 toxicity. So I think you have to be really careful there, just because the prescribing information is pretty emphatic that the drug should be permanently discontinued after grade 2. And so we need more data like that on study
Mhm.
before
Yeah,
I would be comfortable enough doing it routinely, personally.
yeah, yeah,
Can
perfect.
I
Thank
can
you.
I just add
Yeah, please,
something
Dr.
there?
Rao, go ahead.
I think clinically, sometimes it's really challenging to differentiate between a grade 1 and a grade 2 ILD. Especially in Chicago, we just got through flu, RSV, COVID season. So people come in, with all sorts of different viruses. And maybe you find that ground glass opacity on their CT scan. Are there symptoms? You do a respiratory panel, they test positive for adenovirus or RSV or something. So are there symptoms from their virus? Are there symptoms from the ground glass opacities? Is this a grade 2, grade 1 ILD? So I think in clinical practice, it can be somewhat challenging to differentiate between the two, and we have to keep that in mind.
Yeah,
But I
no,
do agree with
for sure.
Dr. Pegram. In practice, I wouldn't re-challenge a grade 2, but it was interesting to see that data.
It's
Yeah,
also
definitely.
difficult to get the diagnosis of drug-induced ILD right too. I was
Yeah,
giving a
yeah,
lecture in Tucson recently, and they were really telling me that they're challenged sometimes in distinguishing cocci from a drug-induced ILD. They
for
really
sure.
struggle with that, and a lot of their patients go on to bronchoscopy with the pulmonologist, and many of them do turn out to have the infectious disease rather than drug-induced ILD. But
Yeah,
it really gets their attention and causes a problem for them in the follow-up of their patients on T-DXd because there's such a high incidence of cocci down there.
yeah, for sure, for sure. Dr. Rao, Dr. Pegram mentioned initially, the patient's median PFS is 40 months, so patients are going to take TDXD for a while. Fatigue becomes an issue because at the end of the day, there is a cytotoxic component to antibody drug conjugate, and the body has to deal with it. And eventually it gets tiring on the body. What are some strategies you've been implementing to deal with the fatigue in your patients?
So I have found that one of the most effective strategies to deal with the fatigue is dose reduction. So we know that there's 3 different dose levels that we can give our patients for T-DXd. And so if the fatigue really becomes a dose limiting toxicity, I try with dose reduction. But I've also done what Dr. Pegram had mentioned, which is increasing the duration to every 4 weeks. So I think those are really the 2 strategies that I use in that setting for fatigue management.
Fantastic.
Some have
Yeah,
championed pharmaceutical intervention. I've never done it, but some people take, drugs, Adderall, and things like this to
yeah,
try to give patients more energy. I'm not in that camp personally. I think dose modification and change of schedule makes more sense instead of adding another pharmaceutical. But I've heard some anecdotes of people using stimulants in that clinical setting to try to get more mileage out of chemotherapeutic based drugs.
so
And
having mentioned that,
oh,
go ahead, Dr. Rao.
I was going to say, what I really hear from patients is that, it's pretty predictable when they feel that fatigue. And so a lot of times they'll know that the first few days after their infusion, they're not going to feel great. So sometimes they'll come to me and say, they have, it's Easter coming up or they have a child's birthday. And so could we delay the treatment 1 week? So I think it's really important to
Mhm.
take some of that into account as well, so that they're feeling good for the events that are important to them in their lives.
For sure. I want to go back to the pharmaceuticals to deal with the fatigue. So we opened a chronic fatigue clinic at my institution, and it became the Adderall clinic. To be honest, like that's all the intervention they do. Everybody goes on those medications. So yeah, yeah. So I hear what
Has
you're
it worked for
saying.
you? Has it worked for you?
It does. Let me tell you the problem. Patients do feel good, but if they forget one pill, they withdraw, and the fatigue they get is so overwhelming
Oh
that it
no.
does more harm than benefit.
Wow.
Wow.
Yeah,
That's
that's the
interesting.
problem with those. Yeah, that's the problem. All right. One last potential side effect that patient ask about and worry about. What about alopecia? What do you think, Dr. Pegram? What do you tell them about alopecia?
Well, you have to be honest and forthcoming and set expectations. T-DXd is associated with an incidence of alopecia of around 40 odd percent. And there was a paper presented, I believe it was at San Antonio, or maybe it was ASCO last year, I forget which one, but there was a paper looking at cold caps. It was a poster presentation, I believe. And it was ineffective. The long half-life, as you mentioned rightly, for
Mhm.
T-DXd is not conducive to a cold cap, which is usually only effective for drugs with short half-life, like
Yeah.
naked chemotherapeutic drugs have half-lives on the order of minutes to hours, and it can be effective there. And for an antibody drug conjugate, the half-life is too long. So not surprisingly, that effort was kind of a failed campaign, at least in the eyes of the investigators on that study. So I don't usually recommend that to patients. I don't mind if they try it. I have no objection to it because it's probably not harmful. But I don't, I tell them the results that were presented and that there isn't high expectation of success and that there may be some alopecia associated with this agent. And for some patients, that can be a deal breaker. As you know, there's a small fraction of patients and percentage of this patients in this country who absolutely refuse anything that's associated with any risk of alopecia. And we do sometimes encounter those patients, and that's a real problem when we have such effective therapies. In this case, neither a taxane nor T-DXd would be acceptable in the eyes of patients who refuse anything that causes alopecia. So those patients are out there, and if they're hormone receptor positive, we'll give them, HER2 targeted therapy along with endocrine therapy, and hope for the best outcome possible there. But otherwise, it's difficult to treat those patients with something that doesn't cause alopecia.
So I heard it from some physicians that say that if patients are really concerned about alopecia, starting with a reduced dose can prevent from happening. Have you heard that, Dr. Rao? Have you implemented that in your practice in patients who care a lot about losing their hair?
No, I haven't. I haven't really heard that, and nor is that the way I start patients on T-DXd.
Dr. Pegram,
I
have
mean,
you heard
one
about that?
exception, the one exception, let's just talk about reduced dose in general, starting dose. Um, the one group where that's successful, in my opinion, are more frail elderly patients, maybe, multiple medical comorbidities. If you think just in your clinical judgment that they can't tolerate 5.4 mg per kg, then you should start at 4.4 for those patients, especially if they're over 65, et cetera. A wise oncologist will tell you to start at a reduced dose. And the same would be true if you're going to give them THP. You would start with a reduced dose of the
Mhm.
taxane. We've all been taught that by our professors back in the day. And so there's no exception with this agent either, that in some cases, starting with a modest dose reduction is sometimes the right thing to do. You can
Mhm.
always start low and go up, but you can't
Yeah,
start high and then go down because sometimes the patients will refuse it if they get too sick.
for sure, for
Mhm.
sure, for sure. All right, fantastic. So now we have here an opportunity because we have representation from all over the US. So, Dr. Pegram is you're representing the West Coast, Dr. Rao, you're representing the Midwest, and I'm representing the South. Let's talk about some prescription patterns. So now it's part of the NCCN. I can start with myself. We met as a group and we decided that the DB09 regimen is going to be our standard of care for all comers unless you have an excuse to give something else. How is it in the Midwest, Dr. Rao?
I would say our group also discussed the same process, that this would be our first line therapy unless you have a reason not to give it, unless you have a compelling reason to give something else.
And the West Coast?
Same. I mean, this is an FDA-approved regimen, which has been deemed to be safe and effective by the regulators. It's the most active regimen against HER2-targeted metastatic breast cancer, bar none, in head-to-head randomized trials in terms of efficacy. That said, the key principle of oncology practice for metastatic solid tumors, HER2-positive breast cancer included, is to maximize therapeutic index. That is efficacy divided by toxicity. So you always have to be mindful of the potential for grade 5 rare ILD. But aside from that, all the other toxicities are very manageable and non-life threatening. The other thing we should mention, just for completeness in this session, is all of these patients need echocardiography every 3 months, just like
Mhm.
as they would on any other HER2 targeted antibody-based therapy. Antibody drug conjugates are trastuzumab biosimilar based, T-DXd included. So you do need to do echoes, and there were numerically more declines in ejection fraction in the T-DXd plus P arm compared to the control arm in DESTINY-Breast09. But it was a small difference. I mean, they were uncommon in both arms, but you still need to be on the lookout for it and monitor accordingly. And it'll, I'm sure, be in your pre-printed orders and your chemo sets and your infusion rooms. And if it's like my institution, the nurses will not give a HER2 targeted therapy unless the echoes are up to date. Period. End
Yeah.
of story. So
Yeah.
strictly enforced at our center.
Yeah, no, for sure, for sure. All right, so now that T-DXd is moving to this first-line setting, at this point in time, unfortunately, we're still not curing our patients, right? Like, or not curing enough of them. So eventually, patient will progress and will need a second, third, maybe fourth-line therapy. So looking at those patients when they're gonna progress, because it's a matter of time about progression. What are we gonna give them next after giving them T-DXd plus pertuzumab in the first line setting? Dr. Rao, what do you think and what factors come to mind to make your decision?
So I think, this is the challenge. We don't really have clinical trials at this point to guide us what to do after T-DXd, but we do know that we have a number of active regimens. I think our principle in treating HER2 positive breast cancer has been to continue the HER2 targeted therapy and switch out the chemotherapy so we could switch to some of our taxane or navalbine based regimens. We have another antibody drug conjugate, TDM1. We have the HER2CLIMB regimen, which we briefly discussed. So we do have a number of different options, but I would say that they're all listed there in NCCN as further lines of therapy, but I don't think we have a real data-driven approach as to what to do next.
Yeah, Dr. Pegram, what do you think?
I think a major factor in the second and greater line with each progression is the presence perhaps of brain metastasis. Because if you have brain metastasis, then the tucatinib HER2CLIMB regimen makes a whole lot of sense in that instance. And so that would be my go-to regimen for brain disease progression after DB09 regimen. Other than that, I'm happy to have a balanced discussion between all the above, including using a Cleopatra-like regimen in the second line. Can do that for sure. That is an option. They're already maybe on the dual antibodies at that point, so it's easy to layer in a taxane at that point if you so desire. Some people, are concerned about doing ADC followed by an ADC. I'm probably not in that camp because it's really the payload that accounts for most of the cross resistance. There are some cases of resistance based on lack of expression of the HER2 target. But I think the majority of ADC resistance mechanisms are largely payload centered rather than target centered. So I don't have any problem using TDM1 after T-DXd, but some people like to use something in between from a different drug class, and then you save the ADC, another ADC for later. I have no objection for that. There's also
Sandwich approach.
sandwich approach. There's also margetuximab plus chemo is another option that's out there for patients to consider. So it's really a menu of different options, and it's a balanced discussion with patients. Let's go over the expected toxicities, et cetera. Routes of administration can differ also. With the tucatinib-based regimen, you could do kind of an oral regimen, for example, especially sub-Q trastuzumab, for example. So those are all the kind of considerations that we use in a balanced discussion about second and greater line therapies.
For sure. All right, so I want to give you a certain scenarios because some people are going to do maintenance. They're going to induce with T-DXd pertuzumab, then go to a maintenance HP plus the PATINA or plus HER2CLIMB-05. If those patients that go on the maintenance progress, they truly never progress on T-DXd. Would you be willing to re-challenge them with T-DXd as quote unquote second line at that point? What do you think, Dr. Rao?
I think definitely. One of the things I would think about, though, is how long it's been since their last T-DXd dose. So, if they had been, on this regimen of T-DXd and then went to best response and were on maintenance HP with or without endocrine therapy, palbociclib, and it's been more than 6 months, we see a lot of these patients on HP now in the Cleopatra regimen. setting for years, I think then in that type of situation, I certainly would be willing to re-challenge with T-DXd before I went to a true second line. Because as you pointed out, these patients didn't really progress on T-DXd. They progressed on their maintenance regimen.
Mhm, mhm. Dr. Pegram, same question, but also I want to add another layer to it. Now that T-DXd is coming to the adjuvant setting with the DESTINY-Breast05, some of those patients will reoccur. Are you going to give them the DB09 when they reoccur?
That's a great question. You know, as a general rule, in all of solid tumor oncology, breast cancer included, if it's been, a year or more since completion of systemic adjuvant therapy or neoadjuvant therapy, whatever the case may be, then we generally use the same drug classes in first-line metastatic solid tumors as were the most active neoadjuvant and adjuvant regimens. So if it's been, a substantial period of time, certainly more than about a year, in my opinion, the longer the better, of course. If it's been 4 or 5 years, I would have no hesitation to use DB09 in the first-line metastatic setting, for example. But if it's been a year or less, it would give me pause. I would have to explain to the patient that, my enthusiasm is diminished if you've had relatively rapid progression after a post-neoadjuvant T-DXd, 14 cycle course. That would give me pause, especially if it's been 6 months or less, or 6 to 12 months. That's more concerning. And I would think about alternatives in that instance, frankly. But beyond that, we use the same, even in the Cleopatra era, we were using taxane and the dual antibodies as neoadjuvant or
Mhm.
adjuvant therapy. And we still use the Cleopatra regimen first line anyway, and have gotten decent results for all these years. So that would still be my preference when
And in the
possible.
metastatic setting, patient, let's say they go on maintenance HP, do you also follow that year time frame, or you'll be willing, if they progress within 6 months of doing maintenance HP, to go back on TDXD?
Kind of the same thing. As Dr. Rao said, it depends on the duration. If they did well for a really long time, and the only reason they had to stop TDXD in the metastatic setting was due to toxicity and not due to disease progression, and if they've been on it for, let's say, a couple of years or what have you, by all means, it probably means it's probably still active. And I would have some enthusiasm to dust it off and use it again in later lines. It doesn't have to be the next line either. It could just be on the table in the salvage setting later at some point. But it would be a consideration if they had a robust response that was durable and the treatment failure was due to adverse events and not due to disease progression.
Fantastic. No, I mean, this was a fantastic discussion about the landscape evolving. So now, as we are closing out, I really want to take from you a single most important message you want the community oncologists to know. For me personally, is that this is a truly exciting time. We're truly moving the needle a lot. Since 2000 onward, we have moved the needle a lot for this subtype of breast cancer that used to be considered the most aggressive subtype, the HER2 positive disease. Since we started implementing antibody drug conjugate, we moved the needle. And here we are talking about a drug that can give you a median PFS of 40 months. We never dreamed about that 20 years ago. So this is really exciting times. I truly wish we can finally give triple negative breast cancer its aha moment and move that needle for that special type of breast cancer, because this is the area of unmet need that I feel the most. But it's really exciting for our patient with HER2 positive disease. Dr. Rao, I'll start with you. What is the single most message you want our community oncologist audience to know about from today?
I think, DB09 really showed that trastuzumab deruxtecan plus pertuzumab in the first line setting was far more efficacious than any other regimen we've seen before. So as you pointed out, this is the Michael Jordan of our drugs that we have for these patients. So use it first because it's the most effective treatment we have. And that's within the guidelines, and it's FDA approved for that use as well.
Perfect. Dr. Pegram?
I'll use another basketball analogy, in this case, LeBron James, because of his
I know.
durability in the league. Because the durability of these responses is also quite extraordinary. A median PFS of over 40 months is unprecedented. So this is the single most active agent against HER2 positive breast cancer, T-DXd. Of course, the regimen is combined with pertuzumab. We will get the T-DXd single agent data in the final analysis of DB09 when it becomes available. It's event driven, of course, so we will see that data eventually someday. But in terms of durability and long-term excellence, LeBron James, has played longer than Michael ever did, even though Michael was more accomplished for the shorter duration that he played than LeBron was. But the two of them are unstoppable.
That's always my struggle. Should I say Michael Jordan or should I say LeBron James? That's always a struggle. All right. I want to thank you all. I want to thank our audience for listening to us. Don't forget to follow Community Health Media for more exciting programs to stay up to date on this ever evolving landscape. Thank you all.